Our next speaker is Kam Wei from Hong Kong, my colleague. He's going to speak on real-life applications of Slet. Kam, please.
Thank you, Chairman. Thank you, everyone. My name is KAM. I'm from Hong Kong. It's my pleasure and honor to be here and speak on the topic of Slet. I don't have any financial interest. I work in the Chinese University of Hong Kong and Prince of Wales Hospital. Let's move on to the next slide. Okay. So Slet is originating from India. It's a ocular surface reconstruction procedure where you have a total limbal stem cell deficiency. You harvest healthy limbal stem cell from one eye. You move on to the sick eye. You dissect. You remove the pannus. And then afterwards, you expose the corneal surface. You put a piece of amniotic membrane on top. And then afterwards, you stick the explants from the healthy eye onto the corneal surface. And then afterwards, you put a bandage contact lens. I'm very lucky to have learned this technique from the two masters, Dr. Virender Samwang and also Dr. San Basu, I think 7 to 8 years ago at LV Prasad Eye Institute. So just now, Dr. Villafon touched on the efficacy of, Slet. This review article showed an overall success rate of about 80%, and most patients had a 2-line increase in vision. So what do we mean by success is defined clinically by a stable epithelialized surface without vascularization. So on the contrary, failure is defined by the occurrence of conjunctivalization, especially in the central cornea, or the recurrence of a persistent epithelial defect. So the Slet journey started in Prince of Wales Hospital after my return from the Slet workshop in 2018. We did the first autologous Slet in August 2018. A few years down the line, we did the first allogeneic Slet for visual rehabilitation. And so far, we have only collected 9 patients, 9 eyes, a very small number. So today, we go through some of these cases. The first patient is Mr. Low, who's a 50-year-old gentleman with very bad alkaline injury to the left eye with a Duos grade 6 classification. He received multiple amniotic membrane and tarsorrhaphy before the eye can epithelialize. And about a year after the chemical injury, he had a Slet surgery done. We transplanted the right eye healthy limbus to the left eye. This is what we see on day 1, week 2. And then on AIOS2025, you can see the explant sitting on top of the amniotic membrane on top. And then at week 4, there's an additional layer of hyporeflective corneal epithelium. So this is what he looked like at 4 months. At that time, you could see the pupil margin. He had a dilated pupil, 360-degree PAS, and a white cataract. So I decided to challenge myself and did an ECC on him, and this is what he looked like 6 months after the ECC. So at that moment, I thought, oh, there's a vascularization. Does it mean the Slet had failed? So we repeated the AIOS2025 at that juncture and look at both eyes. The donor eye and the recipient eye both show the hyporeflective epithelium. And I also did a confocal examination to look at the recipient eye, showing that there's normal corneal epithelial cells. So perhaps the Slet is not yet completely failed. So we move on to a visual rehabilitation by performing a PKP, amniotic membrane, and also tarsorrhaphy about 2 years after Slet. And this is 6 months after the PKP. He had a clear graft without vascularization. He had a vision of 5/200 and aphakia. So what I learned from case number 1 is that AIOS2025 is helpful, but also IVCM is very useful to confirm the presence of corneal epithelial cells following Slet. Second case is Mr. Chung, a retired tailor who had left lower lid basal cell carcinoma, repeated excisions, topical chemotherapy, vision dropped to 2200 with a partial LSCD. At that time, my plan was to do a modified Slet, which I regretted very much. So I put 2 sutures at the top. I think he had healthy limbus superiorly, and that's why I did not do a 360-degree peritomy. On the lower left, you can see the yellow square, which represents the conj autograft. You can see on week 1, the explants are everywhere. So they're not following the circle pattern that you usually see. And this is what he looked like at week 2, a total defect with small amount of epithelialization. And then this is him at week 4, still a large central defect. Eventually, at 6 weeks, his vision improved, but he had a bad central corneal haze with a vision of 20/60 only. So what I learned from case number 2 is that for partial LCD, maybe conch autograft and AMT alone would be enough rather than a Slet. And then early mobilization of the explants indicate unstable grafting. If I had picked it up earlier, maybe I can do something to stop it from becoming worse. So close monitoring postoperatively, preferably by the surgeon, is very important, especially when you start doing Slet. The third patient is a 68-year-old gentleman with, again, bad alkaline burn. This is what his right eye looked like after 2 amniotic membrane endarterectomy. At that time, the vision was light perception, and the daughter was very demanding. She asked me, how many sleds have you done, and are you sure that my father will see after this? So before the surgery, we did an electrodiagnostic, which essentially showed a normal retinal function, trying to convince myself and the daughter as well that maybe this is the way to go. And this is what he looked like on day 1. On the left, you see the donor eye. On the right, you see the recipient eye. And then at week 2, there's only a small central defect, but the rest of the surface has epithelialized. Strangely, his vision did not improve all along. It's still 180/280. And then there's an underlying issue going on. He's trying to claim injury on duty, and he's trying to pretend that he can't see out of this eye. So we sent him to an orthoptist, and they did a malingering test, and he was found to have a vision of 20/80. The next patient is a Madam Tam, who is a 70-year-old lady who had autoimmune conjunctivitis, both eyes. This is what she looked like after a period of topical and systemic immunosuppression. The left eye vision is 200. Potential acumeter show 20/60. The Schirmer is 12. On slit lamp examination, you may notice a loosened area in the central cornea, and this is when the ASOCT becomes helpful to detect any true corneal thinning. So as you can see, it's only because the pannus is thinner at the center, so it's not a genuine stromal thinning. So again, we did autologous Slet on her, and this is what she looked like with time. About a year and a half after Slet, we noticed recurrence of the pannus, which is very similar to a case presented earlier. So we did not do a top-up Slet for this lady, but instead we do a pannus excision with MMC and also the cataract extraction. So similar to Dr. Villavon, we also applied topical mitomycin C at 0.02% for 5 minutes after dissecting the pannus. And we tried to put it under the conjunctiva in the pocket. And then afterward, remember to rinse the surface very well before we proceed to a cataract surgery. And luckily, the cataract is not as bad as the one shown by Dr. Baska just now. So we didn't need to use an additional light source. So this is the pre-op. Post-op, 1 week, she had an epithelialized surface, and this is 1 year after the she had a vision of 20/40 in that eye. So lessons I learned from these 2 cases is that pre-op EDS and PAM may play a role to predict the outcome after Slet, and we have to be prepared to deal with malingering or functional visual loss in some of these patients. And then pre-op OCT is very helpful to detect any true corneal stromal thinning so that you can anticipate the risk of intra-op corneal perforations. And finally, with the progressive pannus, maybe excision with intra-op MMC would be another alternative to a top-up allo Slet or Slet. So now we have done a few autologous Slet. Let's move on to allogeneic. This is a 62-year-old female with bilateral pseudomembranous conjunctivitis. Biopsy showed isolated ocular pemphigus, and she defaulted follow-up, returned later with bilateral total limbostem cell deficiency. So we discussed option whether we do a living-related or cadaveric Slet, and she preferred to have the bad eye done first. That eye had reduced Schirmer score and also a lot of stromal scars, and it did not end well. The defect returned after 1 month after the allo Slet. But nonetheless, she's keen to go on to the other eye, and this is the surgery for the other eye. We obtained the limbostem cell from a donor, a cadaveric donor, very similar to how we do it on a live patient. We cut away the conjunctival tissue, and then we harvest the limbo tissue. So this is her immediate pre-op and post-op photo of the recipient eye. And with time, her vision started to improve until we noted there's a dense cataract in her only eye. So we decided to go in for cataract removal and also intraocular lens implantation. And gradually, her vision improved to 2100 at 1 year post-op. So a summary to the real-life application of Slet is that we have to select our patients very carefully. Note the poor prognostic factors, for example, dry surface, and try to do autologous before you try allogenic. Meticulous surgery is very useful. I attended the workshop at LV Prasad to get proper training and how do you handle tissue, how do you handle amniotic membrane and also the fibrin glue. And also postoperative care is important. Consider adjuvant therapies like punctal cautery, tarsorrhaphy, serum tears, and if you need systemic immunosuppression, liaise with your physicians to balance the benefits and risks with your patients. So in that way, hopefully you have a happy patient and also a happy surgeon. With that, I'd like to thank everyone for your kind attention. I'd like to thank the PWH team and also Dr. Kendrick Shi, who introduced me to Dr. Veranda many years ago, my mentors at LVP, and also the Asia Corneal Society. Last but not least, a little bit of promotion. Next year, APO will be in Hong Kong. I welcome every one of you to come to Hong Kong for the APO as well as the Asia Corneal Society in December. Thank you, everyone.
I think we have time for a question if somebody has one, please.
Not a question, just a comment. When you were doing the dissection for the allogenic slit from the donor cornea, it becomes easier if you can mount it on an artificial chamber, so you're much more control with respect to the thickness of the tissue. If you don't have that, even if you have cyanoacrylate glue, you can just put the glue on the back surface of the stromal side and it will kind of stay, it will not get lifted up, so you can get thinner tissues. Because if you end up having thicker tissues, then the possibility of the bits falling off is higher.
All right, thank you.
It's a wonderful talk.
Thank you, thank you.
A practical challenge when you're harvesting from like a cadaveric source is that unlike a live donor, you don't have conjunctiva to lift up, and sometimes you don't excise it in a way where you have conjunctiva. So you just pinch it and excise it, it becomes easier. So
we deliberately asked our eye
Yeah.
bank to leave behind a
yes,
conjunctiva.
then it becomes easier.
Yeah.
But if you don't have it, it's called a pinch biopsy, where you just use some forceps to pinch up the limbus and cut it. So that works better.
Thank you. Thank you very much.
Thank you.